You two, you can unmute and say hi to us for a second. All right. Without delaying, now I would love to invite Mr. Wilson to give the introduction to our guest. So, Mr. Wilson, you are most welcome.
Thank you very much, Danny. Good evening, everyone. Hi, Oswald. It's a long time.
Hi, Wilson.
Okay. I'm going to share with you a short biography for our speaker of today. Ladies and gentlemen, it's a privilege and honor to introduce Mr. Oswald Benimana, RN, BSN, MCC, Medical Surgical Nursing, the Director of Nursing and Midwifery at the Teaching Hospital of Butare, a distinguished honorary clinical lecturer at School of Nursing and Midwifery at College of Medicine and Health Sciences at University of Rwanda, member of the Operating Room Global Rwanda chapter in charge of policy and clinical guidelines. Oswald Benimana is a distinguished Rwandan healthcare professional with more than 13 years experience serving as clinical as a nurse, and now he is the director of nursing and midwifery at the University Teaching Hospital of Butare, CHUB, with a career marked by a dedication to improving healthcare services. Benimana has become a pivotal figure in the nursing and midwifery community in Rwanda. Benimana's academic journey laid a strong foundation for his career. He earned a bachelor's degree in general nursing from the University of Rwanda, followed by a master's degree in medical surgical nursing from the same institution. His advanced education equipped him with the experience and expertise and skills necessary to excel in various nursing roles and contribute significantly to healthcare quality, like curriculum development and review, licensing examinations, and so on. Throughout his career, Benimana has held several key positions within the healthcare sector, particularly at CHUB. His extensive experience in the operating room has been instrumental in enhancing the quality of surgical service and patient care. Benimana's commitment to excellence in healthcare delivery is reflected in his numerous publications on infection prevention and control, quality improvement, and surgical care practice. In addition to his role at CHUB, Benimana serves as policy and guideline coordinator for the Operating Room Global Rwanda chapter. In his capacity, he plays a crucial role in developing and implementing policies and guidelines that ensure the highest standards of care in operating rooms across the country and the globe, as he's very active in hospital accreditation program. Oswald Benimana dedication, expertise, and leadership continues to drive positive changes in the healthcare sector, making a lasting impact on patient care and medical practice in Rwanda. We are privileged to have Oswald Benimana as speaker for this TORG Rwanda webinar, where he will share his valuable insight and experiences on enhancing healthcare quality through the best practice laid in clinical audit. Please join me to welcome Mr. Oswald. Thank you very much and welcome, sir, for your presentation of today. Thank you.
Thank you, Wilson, and thank you to everyone for welcoming me. And I'm happy to be with you in improving the operating theaters standards. And also I'm happy to be part of this platform because I'm sure that I will gain a lot because we are together with many expert people. So I'm eager to learn from them as we shall just learn from each other. Can you see my slide?
Yes, Wilson, your slide,
Yes.
we can see it.
Yes, we can. Okay.
So we are going to talk about the enhancing of healthcare quality through conducting the clinical audits as the best practices. This is the content that is going to be covered. We shall talk about briefly the introduction and the definition of what does a clinical audit mean. We will see the objectives of conducting the clinical audit, and we will see some cases and also consensus for the rationale of doing the clinical audits. And we will go through the process of the way the clinical audits are conducted, and we shall see some identified barriers to clinical audits. And I will just share with you some clinical audit tools, and I will just show one slide that just to show the difference between the research and the clinical audit, and then we will go to the end of the presentation. We might wonder ourselves, why do we need to conduct the clinical audits and their impact they have in improving the quality healthcare. And these clinical audits, they are essential instruments in the healthcare, and they serve as evaluating and also improving the standards through the patient care delivery. They provide a thorough analysis of the medical procedures, the protocols, and even assess the patient file to see whether they comply with the standards or the guidelines that are available. Therefore, providing the improvement plan. They aim at carrying out a series of clinical audits across various healthcare domains or specialties or even department. And they also serve at gaining the understanding of what needs to be done properly vis-a-vis the clinical practice, and also to encourage the systems we are working in improvement. It also helps in reviewing the professional activities through internal evaluation of suitable efficacy, efficiency of the services we are rendering to the customers. They also provide the actionable recommendation for practice modification, which will then improve the clinical care and also lead to very good outcome to the patient. The clinical audits, there have been the attempts from the decades about the improvement of the patient care. And there have been the establishment of the clinical governance. These are the new concepts in the healthcare settings, like here in Rwanda. This clinical governance came during the process, establishment of this clinical governance came during the process of the accreditation. And these clinical audits are among the key elements of the clinical governance. The clinical audits are done structurally from all the hospitals, and the most important objective of conducting the clinical audits is to determine whether the clinical guidelines or other agreed best practice are being followed properly during the patient care delivery. Some of the domains of the clinical governance, there is the patient involvement, like the use of consent forms. There is these clinical audits and also the clinical improvement project. There is the staff engagement, and also there is the risk management and the safety issues. And of course, the data that is being provided needs to be shared to all the stakeholders. And from these clinical audits, we also provide the education and also training programs, because the staff or the stakeholders must share the information or the data that we have got from those clinical audits. And to be able to achieve this, we need this strong teamwork. There is need of a change of culture to have the behavior change. There is a need of leadership engagement, and we need to think about the system instead of thinking about working like individual or working alone. And of course, all the people involved must be accountable. The clinical audits are a proven method of quality improvement. They provide the staff a systematic way of looking at their practice and then make the improvement whenever necessary. They can be done straight away from the records management, or throughout the diagnosis, or even during the treatment phase of the patient. And they can also be done during the post-operative phase and even during the follow-up periods. They can also be a prospective or retrospective, and we usually use the medical records data. We can also interview the patients or even the staff and even the caregivers. And also we need to make sure that we use available resources. As said, a well-performed clinical audit obviously results in improvement in the standards of patient care. So the concept, as I've said, of this clinical audit, it's new. It came here in Rwanda. It came throughout the period where the hospitals were busy in a accreditation process, and it's not complicated, the process. It's just, it has evolved out of the desire to make sure that the health services that we are providing are in line with good practice. And also they are delivering the kind of expectation or outcome that our consumers or patients expect from us. The clinical audit is recognized to be a powerful vehicle change in practice, provided that change is pursued. Those who look to facilitate the process of audit, they usually call it the closing. We need to close the cycle, and the cycle is closed only when the audit cycle has been completed. And of course, there is a change in practice that has occurred, and that practice we need to make sure that is embedded in a new order of what we do. As definition, a clinical audit is a professionally led initiative which seeks to improve the quality and outcome of the patient through the clinician examining their practice and the results and modifying the practice where indicated. It's also a quality improvement process which aim at improving the patient care and outcome through the systematic review of care against the criteria or the standards that are set. And then we need to ensure that there is the implementation of that change. It's also a systematic and critical analysis of the quality of clinical care, which include the procedures that are used for diagnosis, treatment, or even the care delivery, and also to take into consideration the associated use of resources, which might result in the outcome, in better outcome, and also improve the quality of life to the patient. The objectives of clinical audit are to assess the practice across the clinical services, to identify the areas which require the improvements, to implement the necessary change for service delivery improvement, to raise the awareness and the involvement of staff about their performance, to inform the training and development of programs for across the all professional groups. And also it serves as a tool to develop the new guidelines or update or make the amendment to the existing ones. So about the clinical audits, we need to, hello, Danny?
Hello, we still hearing you, so you can
Okay,
keep
thank you. We needed to know from whatever we do or whatever our professional background is, there is a requirement to keep ourselves up to date and also to make sure that we pursue the best practice at all the times. This clinical audit is a useful tool for practitioners and the teams to review and evaluate their practice and also introduce the necessary changes, as said. And this audit is not purely about litigation avoidance. It's also about making sure that the services are operating in line with good practice in the first line. And as the accreditation process, I mean, all hospitals here in Rwanda are going through, it's one of the requirements for the clinical services to be able to follow or to meet the accreditation requirements. Regarding the purpose of audit, we need to identify the opportunities and to implement the improvement in the quality of clinical care, training and continuity education, and effective use of resources. There is also the responsibility for implementation, the audits, it rests with the senior clinicians into their respective domains. Sorry. Can you see my slide?
Yes, your slide are clearly seen.
Yes, we can see.
There is a need of effective coordination, and this is required between service or departments and at all levels across the system. The audits should involve the objective peer review of the patterns of care, and there is a need of being sensitive to expectation of the patient and other clinical disciplines. And also we need to be based on scientific evidence of good clinical practice. All types of patients or clinical conditions or activities, they are eligible for audits, and the priorities are usually defined locally. It might be at the service level, departmental level, or even at the hospital level, like it can also be at the national or even international. The clinical staff should be provided with time, data, technical assistance, the library support, and the training, which are all required to fulfill the agreed programs of audit. The documentation of clinical care and the audit should comply with defined standard of good practice at any system that is in place. About the types of audits, we might have the structure, it can be structure, we can audit the process, we can audit the outcome, or just the combination of one or two or three, or these the three. Like structure, it's like auditing the capacity of the healthcare professionals, the way they respond to the patient needs. An example of the process audit is like auditing the activities that are performed with respect to patient needs, like surgical intervention, drug administration, and so on. The audit can also auditing the outcome, where we just need to observe the consequences of the services that we've provided to the patient whom we are supposed to care for. The clinical audit principles, first of all, we need to make sure that there is quality in the audit we are conducting. There must be some ethical responsibilities. We need to make sure that we disseminate the findings of the audit. And this audit program should generate the education and the training opportunities to all stakeholders. And of course, it needs the engagement of all stakeholders. Like I've said, there is a strong need of multidisciplinary approach, and there is a really need of this collaboration and partnership between all the people who are involved in patient care. And of course, this audit must inform the service practice, therefore changing the way we have been doing things. The clinical audit process, it passes through 8 stages. Stage 1 is about selecting a topic for an audit. And this topic usually comes from the issues that are raised. It might be from the patient complaints or staff. It might be from risk management perspective. It might be from a significant clinical incidents that happened. It might be to audit the guideline, the policies, or even SOPs that are in use. And the selection criteria, we need, first of all, to define the criteria that we are going to be based on. And in hospital settings, we just selected the topic basing on the high volume, like we are having many patients who are coming having a certain, a condition. It might be a high risk being a procedure or even the patient condition. It might be prone problem. It might be from a sentinel events that have happened. It might be from the high cost or any other activities. These topics, they must be selected at service level, and that service is the one that is responsible of justifying why they have selected that criteria or that topic to be audited. Stage 2 is about to identify or setting the standards. The team that will contribute, that will participate in the audit, must identify which standards or guidelines exist from the selected topic. And if those standards or guidelines are not available, they will develop them by their own. And those, they can come from the evidence-based literature that is available, or from the research publications that are available. They can come from the policy frameworks that are present in the institution. They can come from the benchmarks, or they can even come from the senior clinicians' views, from what they have been taught at school, or from what they have read from the available literature or research, as I've said. Stage 3 is about preparing the audit. We need, first of all, to communicate the people who will participate in the audit. We need to communicate them about the standards that are set, or to inform them about the guideline that is present, that is going to be audited. And then they need to gather the necessary support and of course, to review the audit, the action plan. The selection of criteria must be prioritized, and of course, the indicators, we can get them from the local policies and different from the development process that are in place. After the preparation of audit, we use the clinical audit proposal form that must be completed, and it serves as assisting the proposers or the audit team to make sure that there is appropriate background research that support that clinical audit, and they must also show the methodology that is going to be used, and of course, they propose the timeline for the audit and even the reporting. And they must also anticipate the resource implications and request them whenever they are needed. And it needs the operational approval from the clinical audit committee that is at the hospital level, and that serves as making sure that the clinical audits that are being conducted are in line with the accreditation or the hospital requirements. Each audit proposal form must have the evidence that all the requirements or confidentiality are granted. The health and safety of all participants must be granted, and the ethics approval must be sought and granted where applicable, and the informed consent must be obtained if required. Stage 4 is about the review of service against the standard set. This is the time where the clinical audit will go to collect data, which might be from interviews of the patient or the caregivers. They might go to the documentation, what is documented in the patient records. And then after collecting data, they will compare them with the standards set and then analyze and then produce the findings. Stage 5 is about the gaps identified, and these gaps identified are usually the description of the differences between the current clinical practices and the desired practices or the standards. It's about measuring or comparing the findings from the audits with the standards that are set. And then after the report and identification of the gaps, we need to provide the feedback to the participants. These participants might be the entire audit team. It might be to the concerned service where the audit took place. And this must be owned by, like you said, there is a need of leadership engagement. It must be owned by the hospital. Therefore, that audit must be a hospital document that will help in informing the public the process that the hospital is in changing or improving the standards. Stage 6 is about developing the improvements action plan. Making improvement is the key stage of effective audit, and we need to make sure that it underwrites the purpose of the clinical audit. It is for the hospital management, as I've said, to implement the change and to make sure that the change, there is a monitoring way of the implementation, which might be affected by the organizational or resources constraint in some instances. In other cases, the training issues may emerge from the findings of an audit, and improvement will affect the change through the trainings. Stage 7 is about the implementation of the action plans and, of course, monitor those implementation. And then the last stage is about to review or conduct the re-audit, and at this time, that's where the cycle is closed, as we have seen in the introduction. This is just a a diagram or an image that describes all these steps as I've described them from the previous slide. And the barriers to clinical audits, some of them maybe are related to my working place because we get them during the time we have been conducting these clinical audits. Firstly is about the poor relationship between the professional groups. Let's say, like we might say we are going to conduct a clinical audit about the way we are managing the DKA, diabetic ketoacidosis, like an example. And then from that, there is the medical component and nursing component and all other healthcare professionals. So if there is no strong connection and better understanding from all those groups about why we need to have that project, there will be the barrier in conducting these clinical audits. There is also the poor organization or relationship between specialties, department or domains. Like the example I was giving, like the DKA are received or admitted from the accident and emergency, and once stabilized, they are admitted or sent to internal medicine. So if the internal medicine and the accident and emergency are not having the common understanding about the rationale of conducting that clinical audit, there will be a barrier in between. There is also a lack of commitment from senior management. It doesn't happen from our setting because we are in the process of accreditation. It means this program must be owned by the hospital. There might be the workload pressure from the staff, from the audit team, or lack of the protected time to the team that needed to help in conducting the audit. There might also be lack of knowledge and skills to conduct that audit, reason why there is a need of education or training programs of standards available or guidelines available so that people can be familiar of what they will do and have better understanding of how they are going to conduct the audit vis-a-vis the standards or guidelines that are available. So research is not similar to the clinical audit, but the clinical audit has some components of research. And sometimes it is very difficult to determine whether the project is a research project or a clinical audit. But the major difference relies on, because the research asks the question about what is the best practice, and then it will seek to find the new knowledge. While for the clinical audit, it's just about seeing whether we are following the agreed or evidence-based practice. And then the auditors will try to find out if we are achieving the things we have agreed as we have said. Research is about discovering the right thing to do, while the clinical audit is about determining whether the right thing is being done. The research is about the series of one-off project, while the clinical audit is a cyclical series of reviews or audits. The research, it collects the complex data, while clinical audits collects routine data. And the research goes through the experimental process, while the clinical audit, it's just about reviewing what clinicians do. And research is also often it's possible to generalize the findings, but for the clinical audits, it's not possible to generalize the findings. For the clinical audit, to make sure that it is completed, these are the different templates that must be completed. There must be, first of all, this clinical audit framework that must be owned by the hospital. And it is the one that provides the guidance on how the clinical audits must be performed. The clinical audit proposal form must be completed once you have agreed on the topic that is going to be audited, and this proposal form should have the background and also the objectives and the rationale behind of doing those audits. As I said, is it because of high risk? Is it high volume? Why? The intent of selecting that topic must be clearly documented in that proposal form. The clinical audit project, it has the checklist which shows all the elements that must be present, and we need also to have there is a clinical audit template that must be well completed, and after there is a clinical audit action plan template which helps or which serves as the way we document the gaps that have been found from the audits. And we need also to provide the report. There is a template that must be used. And of course, as this must be the hospital property, it needs to have they need to be recorded into the hospital registers, and those registers are mainly in the accreditation in the quality assurance management office, as they are the ones who will provide the reports at hospital levels. And of course, there is the clinical, the templates for the clinical audit team that must be completed by all the people who have been involved in the development of clinical audit. By concluding, first of all, we need to understand that the clinical audit is not complex, and it can be done by whoever from all the healthcare professionals, being the medical, being the nursing side, being the midwife side, being the other allied healthcare professionals. There should be for sharing experience, and these clinical audits are highly likely to succeed once the multidisciplinary approach has been used. And we should not forget that the only reason for engaging in audit is to deliver change in practice for benefits of the patient, and of course, enhancing quality service delivery. And once our patients are satisfied from what we are doing, or the outcome of the patient are being good, we as the staff are also satisfied from what we have done. The clinical audit must not be seen as luxury. No, they need to be reviewed as the fundamental requirements of service provision. And it is the responsibility of all of us as healthcare professionals to make sure that there is investment in conducting these clinical audits, as they help us in like marketing our institution, because we are showing the public or the community that we are doing the right thing compared to those that are standards. And the clinical audits are believed to be the heart of clinical governance, as we've said. And they have shown to be effective and the systematic way to improve the quality of patient care. The process of clinical audit should involve all medical and non-medical staff, as we have said. As we know, this non-medical staff comes from regarding the logistics, like we might need for the printers to print the audit forms. We might need the computers. So that's the hospital management. That's where it needs to be involved, because it's a clinical activity, but it also needs the involvement from the other supporting staff. And we also need to make sure that there is a team that coordinates the clinical audit program. Like at the hospital level, we have like a joint clinical committee which serves to oversee the clinical guideline development and also the clinical audit development. And that committee, it's at central or at hospital level, but within the departments or within the directorates, there are the subcommittees that are responsible of overseeing the clinical guideline development or clinical audit into those different services. Like we might need to audit a guideline or the standards that are purely nursing, then it will come from the nursing side. If it's purely medical, it will come from the medical side. And if it's purely from allied healthcare professionals, it will come also from there. But the main objective is to make sure that all those domains at improving the quality of service delivery, which will in turn improve the satisfaction of our customers, because the outcome will be okay, and then also we will be satisfied as the intervention we are providing are really being helpful to the patients. This is the end of my presentation. Thank you so much. Maybe it's time for comments, inputs, or questions, because I know some of you, many of you are involved in this accreditation process from different hospitals, mainly in Rwanda, like Danu is at King Faisal, or even Wilson, who has even been the head of quality assurance management at our hospital. So please, your inputs, comment, question, you are welcome. Thank you.
Thank you very much, Mr. Oswald. We really appreciate your amazing presentation. Actually, it was
Thank you.
One of the most interesting presentation we had since our chapter has started in Rwanda. So we did appreciate your work.
Thank you.
Yeah, as you have, you took us through a different aspect of clinical audit. You've taken a lot talking about quality improvement and also showing us how it's anticipating patient safety, also in efficiency of what we do in, as you said, in the collaboration of services, like different services in hospital. And as well, also, you've mentioned also our professional development. As we all know, like if any professional really need to grow, it's really need to go back and analyze what they really do, if they do it right. And there is no way to see that apart from using or doing different clinical audit. So we really thank you to choose this topic as it goes cards in a different discipline. So dear members, now it's...
Thank you, Danny, also for being my co-presenter. I've seen from the comments you have been answering some of the questions. That's why I've said it's not new for you and even Wilson. I really appreciate your contribution, and every concern that have been raised on the comments was really answered in a perfect way. Thank you, sir.
Thank you very much, Mr. Saldi, for appreciation. So, and now it's an open discussion now. We would love to invite everybody in the room now to have a comment, or if there is some more other question that was not asked in a chat group. Okay, now it's a good time to ask Oswald for some point, maybe clarification or some question to discuss as we're here. So it's a time to ask questions if there are. I hope everybody now who has question can unmute and ask a question, and you can respond quickly. Akpan, are you there? Alexis, can you hear us? You can unmute and talk to us. Alexis? I don't know if Alexis is hearing us. I was just inviting him to really know if he's happy with how we responded to his questions. Alexis, are you there?
Yes, I'm here. I'm in journey. Just here. It's very noise. I don't know if you are hearing me well.
Yeah, we are hearing you clearly. So were you happy with the response we responded, or you still have something for Oswald to clarify?
Yeah. I have answered my question. So thank you for the presentation. And I really happy to be with you all the time and keep update us for the new information you have get.
Okay, you're welcome. Thank you very much. Mukal Committee, do you have something to comment or question or something to add on this presentation? Mukal Committee?
But I have listed some comments. Really, it is a very interesting topic.
Sorry, Mukal Committee, your line is breaking.
We can't hear you.
So I would love to ask Esther. Esther, are you there? Do you have any comment?
You can see that Wilson probably has raised the hand.
All right. Wilson, you're welcome.
Thank you, Oswald. Thank you, Danny, for this time. Oswald, thank you very much for the very insightful and informative presentation. It reminded me about my time at Sashibe.
You were baby.
My baby was clinical audit, quality improvement. Thank you very much. It was very, very detailed and informative. What I would like to request just to help us throughout this journey. I think this is the beginning of this program at TORG Rwanda, the clinical audit. So I think it will be better when you can help us to just to adopt or draft some of templates you showed us, so that if or someone who needs to start can have a guidance. Thank you very much. I think we will need you throughout this journey. Thank you. I'm humbly just saying I'm glad to have you on this platform. Thank you. Yeah,
I'm glad to be with you too, and thank you for accepting me to join the team. I'm really very happy, and I wish we might work together and make an impact from whatever we do or from whatever we need to achieve.
Sure. Thank you very much. Yeah.
Thank you.
Thank you, Wilson, for the comment. And now I see Mame. So Mame, are you there? Can you hear us? Do you have something to tell us?
Thank you so much, everyone. Thank you, Danny. Thank you, Mr. Oswald. That presentation was really, really good. I mean, every hospital or every institution should be committed to quality improvement. And before you can implement a change, you need the evidence-based audits and the results of that as well. For example, in my department recently, we pioneered a model. That model is to consolidate treatment protocols into one day instead of having patients go back and forth and have multiple appointments. And we had to do the audits because it was the very first of its kind. We had to do the audits for 12 months just to see the results of what we pioneered and see how that model can be scalable. I mean, how every other institution can implement that and see, oh, this is really working. So we had to conduct an audit. And fortunately, when that audit was conducted, we discovered that we slashed the waiting list from 4 years. Usually for that procedure, patients would have to wait for 4 years, 3 to 4 years before they can be booked for the case. But because we started the model that actually consolidated multiple appointments into one, so we get everything that they needed to do on the same day, even an aesthetic review and everything, and patient won't have to go back and forth. And we discovered that after the audit, we were able to slash 4 years waiting list to just 3 to 4 months. So to just 3 to 4 months, that was audit outcome. Audit brought out the results, and people could actually see, wow, this is really working. Because of that, we were shortlisted for a national award. We were published on multiple newspapers. And I'm telling you, so audit is very essential. Every department needs to know how to go into audits. They need to be committed to quality, and they need to be committed to the highest possible standards of practice, especially for patient safety. As Wilson said, I believe it's the very beginning, so we definitely need drafts and templates, even that other institutions or other countries in LMICs can use and implement as well. And definitely, if any of the leaders or any institution, if they need help in this regard, you are a pro in the field. I mean, you've been doing that accreditation stuff and everything. So you would, if you don't mind, if you can help to guide them as well. And definitely we will need to like templates that people can really use, or maybe another session that we can do, maybe a part 2 of this with case scenarios, and just start with a case and maybe have examples, live examples that we can talk about and walk people through that from scratch, from start to finish, how they can do that. I believe even as we saw recently that TORG has been invited to become part of the G4 Alliance. G4 Alliance, they have a high-level relationship with the United Nations. They've got high-level relationship with WHO. And whatever they want to implement from the grassroots, it's going to come from TORG. And that is going to be very soon. We are in the final phase of the process. And a lot of it is going to be audits, research, grassroots, evidences, because we want to implement change. For example, if this facility is having a problem, or if they are lacking in resources, we want to identify hospitals that would trial the audits in LMIC regions and kickstart that. So I believe you are going to be a very, very good professional person to get involved with that when we start that with the G4 Alliance as well, because they want to try out that in recent times. And we want to pioneer some changes and implement some changes in operating room environment from the grassroots. And definitely we need to start the audit. The proposal is in process, and hopefully it's going to finish very soon. And as soon as that is concluded, I know we will need your help in that regard, if you don't mind. So thank you so much for the insightful and detailed presentation. Thank you for sharing relevant knowledge on clinical audits. If you don't mind, we also need the notes as well that we can share with others. And this session has been recorded. We will share the replay, even though it was live streamed, but we will have a proper replay shared in another few days, hopefully. And thank you so much for that. I want to say thank you to the TORG Rwanda executives for facilitating this session, organizing this session. It's been very insightful. I know the webinar for the chapter level is once every month. Hopefully, I think next month we can do something related to cardiac surgery, open hearts. open heart surgery, maybe the basics and everything, and bring a professional in from King Faisal and see how we can work towards that. So thank you so much, everyone. Thank you to everyone who connected. Thank you to those on YouTube connecting live and joining us from all different platforms. We really want to say thank you for joining the session and have a lovely evening ahead. Thank you and bye.
Thank you.
Thank you so
Bye.
much. Bye. Have a nice day.
Thank you. Bye.
Bye.
Thank
Ciao,
you.
ciao.
Yeah.
Thank you, Danny.